Hello everyone, and welcome back to Health Code Blueprint. Today we're reviewing ICD-10-CM Chapter 19, focusing on injuries, poisoning, and the consequences of external causes. This chapter is highly logic-driven, and we'll break it down using a simple clinical framework that mirrors real-world coding decisions. Before we begin, a quick reminder. This presentation is intended for educational purposes only. It does not constitute legal, compliance, or coding advice. Always follow official ICD-10-CM guidelines and your organization's policies when assigning codes. Let's get started. Chapter 19 lives and breathes through the seventh character. It tells the story of where the patient is in their healing journey, not what the provider's job title is, and not where the patient is physically located. When the patient is receiving active treatment, such as surgery, emergency care, or evaluation by a new or existing physician, we use the seventh character A. Once active treatment is complete and the patient is simply healing. Maybe they're getting a cast change, a medication adjustment, or having external fixation removed, we shift to D for routine healing. And then we have S, which is used for sequela. These are the long-term consequences of an injury, like scars after a burn or chronic pain from an old fracture. When coding sequela, we list the current condition first, and then the original injury with the S character. And remember the critical rule. We never use aftercare Z codes for injuries. The acute injury code stays active with the correct seventh character. When multiple injuries occur at the same site, sequencing matters. We always start with the most serious injury, as documented by the provider. Superficial injuries like abrasions or contusions are not coded when a more severe injury exists at the same location. If there's nerve or vessel damage, the primary injury is coded first, and then the nerve or vessel injury is added as a secondary code, unless the nerve or vessel injury is the primary injury, in which case it moves to the top. And one more important rule: if the injury occurred as a result of medical intervention, for example, a complication during surgery, we do not use Chapter 19 codes. We use the appropriate complication code instead. Fractures come with their own set of default assumptions. If the documentation doesn't specify whether the fracture is open or closed, we default to closed. If it doesn't specify displaced or non-displaced, we default to displaced. For open fractures of the forearm, femur, and lower leg, the Gastillo classification is required. If the provider doesn't document the Gastillo type, we must assign the seventh character that corresponds to type 1 or 2. And here's a key distinction. If a patient with known osteoporosis fractures a bone from a minor fall, we do not use a traumatic fracture code. We use M80, which captures pathological fractures due to osteoporosis. One of the most important rules in Chapter 19 is the No Z code rule for fracture aftercare. Even during follow-up visits, we continue to use the acute fracture code with the appropriate seventh character. When dealing with non-union or malunion, we use specific seventh characters that identify the complication. And if the patient delayed treatment and is now presenting for the first time with a non-union, we still use the initial encounter character. For physeal fractures or growth plate injuries, we assign only the code that identifies the type of physeal fracture. We do not add a separate code for the bone involved. The physeal code already captures that information. Burns and corrosions follow a very structured hierarchy. We sequence by severity followed by the anatomical site and last, the cause. Burns include thermal, electrical, and radiation injuries. Corrosions are burns caused by chemical agents. When multiple degrees occur at the same site, we code only the highest degree. So if the right thigh has both second and third degree burns, we code only the third degree burn. When multiple burns occur across different sites, we sequence the most severe burn first. The rule of nines helps us estimate total body surface area involved in burns or corrosions. These percentages guide when we assign T31 or T32 codes. We use these codes when the site of the burn is unspecified. Additional data is needed, such as for burn unit mortality. A third-degree burn involves 20% or more of the body surface. And remember, we never use T31 or T32 for sequela. Burns have their own healing logic. A non-healing burn is still coded as an acute burn. If there's necrosis, we also code it as an acute burn. If the burn is infected, we add an additional code for the infection. And here's a unique situation. A patient can have both a current burn and a sequela of a previous burn at the same time. Burns heal at different rates, so it's completely appropriate to see both A or D and S characters in the same record. This section is all about understanding the difference between an adverse effect and poisoning. An adverse effect happens when the patient takes the correct drug, in the correct dose, by the correct route, but experiences a reaction. In that case, we code the manifestation first, and then the T code with the fifth or sixth character 5. Poisoning occurs when the drug is taken incorrectly, wrong dose, wrong substance, wrong route, or when there's an interaction, such as mixing prescribed medication with alcohol or another drug. For poisoning, we sequence the T code first, followed by the manifestations. When intent isn't documented, we default to accidental. If the provider specifically documents undetermined, then we use the undetermined intent codes. Drug interactions are always classified as poisoning, even if the patient took their medication correctly. If a prescribed drug interacts with a non-prescribed drug, or with alcohol, and toxicity occurs, we code it as poisoning. Intentional overdose is also coded as poisoning. Underdosing happens when the patient takes less medication than prescribed or stops taking it altogether. In these cases, we code the medical condition first, the relapse or exacerbation, then the underdosing T code, and finally, if known, a code for non-compliance or complication of care. Underdosing is never the principal diagnosis. Toxic effects, on the other hand, involve harmful non-medicinal substances, things like chemicals, plants, or environmental toxins. We code the toxic effect first, then the manifestations. When we're coding confirmed cases of abuse or neglect, there's a very intentional sequence we follow to make sure the record tells the full story. We start by assigning the abuse code, because that establishes the nature of the event. Next, we add any injuries or mental health conditions that resulted from the abuse. After that, we include the external cause code to show how the event occurred. And finally, we add the perpetrator code, which identifies who was responsible. Now, if the situation was only suspected and later ruled out, we don't use the T76 category at all. Instead, we assign the appropriate Z04 code to document that abuse, rape, or exploitation was evaluated and formally ruled out. This keeps the record accurate and compliant with coding guidelines. We only assign a transplant complication code when the complication affects the function of the transplanted organ. The structure is, first, a T86 code for the transplant complication, followed by a secondary code describing the specific complication. For example, many kidney transplant patients have chronic kidney disease, but CKD alone does not mean the transplant is failing. We only assign T86.1 when rejection or transplant failure is documented. Intraoperative or post-procedural complications found in body system chapters take priority over Chapter 19 T codes, unless the index specifically directs us to a T code. For pain due to a medical device, we use the appropriate T code, and then add a code from G89 to describe the nature of the pain. Some T codes already include the external cause, so we don't double code the external cause in those cases. This final slide pulls all the major concepts together into one quick practical checklist. We start with the mechanics. A tells us the patient is in active treatment, D signals routine healing, and we never use Z codes for injury aftercare. For thermal injuries, we always code the highest degree, treat any non-healing burn as acute, and rely on the rule of nines when body surface area matters. In trauma cases, we sequence the most serious injury first, apply the default rules for fractures, and use the Gastillo classification for open long bone fractures when required. And finally, the systemic logic. An adverse effect means the drug was used correctly, poisoning means something went wrong, and underdosing is never assigned as the principal diagnosis. Think of this checklist as your compass, a quick guide to help you navigate Chapter 19 with clarity and confidence. Thank you so much for joining me for this deep dive into Chapter 19. I hope this framework helps you approach injuries, poisoning, and external causes with clarity and confidence. I'll see you in the next episode.